Welcome to another episode of the Pipeline, an S&P Global Market Intelligence podcast that focuses on all things M&A and IPOs. I am Joe Mantone, an editor with S&P Global Market Intelligence, and today we are exploring deal making in the healthcare space. And helping us break down the activity is Singh, a managing director in the M&A practice for the healthcare advisory firm Kaufman. The reason why I wanted to dive into healthcare a little bit is because we recently published a report on M&A activity, and it showed the total value of U.S. M&A announced deals going up for the year, and it's been driven by large deals. But we haven't really seen that so much in the healthcare space. However, a recent report from Kaufman had noted that they expect to see some increase in the activity amongst the hospitals and health systems. So I wanted to have someone on from the firm to talk to about that. And Anu has been gracious enough to join us today. So thank you, Anu.
Thank you, Joe, and to S&P Global for featuring healthcare services as one of their pipeline podcasts.
Okay, maybe to start off a little bit, can you give us a little bit of background about yourself and your firm and what types of clients you typically advise?
Happy to, Joe. My name is Singh. I'm a managing director at Kaufman. I've been with the firm 19 going on 20 years. Our firm focuses on healthcare services. Historically, we spent a lot of time with mission-based, non-for-profit types of organizations. Now we work with an array of client types and also providers of capital to healthcare services companies. That includes hospitals, that includes physician practices, a number of other ancillary and other ambulatory and outpatient service providers as well. We're really excited to have the conversation with you.
Yeah, it sounds like you work across the spectrum there.
Yeah, particularly on healthcare services. So we don't see a lot of pharma or health IT or product. So I think most of our conversation today will be around healthcare services. And certainly there's a lot to talk about, Joe.
Okay. So yeah, what is the most active area in your practice right now?
So in terms of the most active areas, Joe, across the hospital spectrum, they're all pretty active. And what we're seeing is smaller hospitals that to date have found a way to create a path to viability. Now, in facing some of the industry headwinds I know we're going to talk about, and seeing a lot more challenges, and they're looking to uplink to large organizations. We also have a middle cadre of hospitals and health systems that have performed quite well and probably have a long-term sustainable path for survival, but their overall success in the market may be influenced by how they can invest and transform their businesses to the requirements of healthcare service companies going forward. Some of those may be looking more strategically for partnership opportunities. And of course, the largest of the systems, national, for-profit, non-for-profit, they're always looking to think about the right portfolio of markets they're in and the types of organizations they're in. So they're going to be pretty active, and we expect them to stay pretty busy in this market as well. That's just the hospital side. What we're also seeing is whether it's a physician practice, a specialty practice, lab services companies, diagnostic companies, ambulatory, outpatient, urgent care, all those things that go around acute care or what we consider to be the inpatient enterprise, those are also very active in nature as well. They are looking for who are the convener and organizers of care in their markets, and they're looking to partner, joint venture with a lot of these organizations. So from our perspective, we expect a lot of activity from a lot of different sources of nearly all the different types of participants in the healthcare ecosystem participating in M&A activity going forward.
You mentioned that it's pretty active, but are we seeing that in the actual number of announcements of deals?
I think we are, but I think we always have the vagaries of this quarter or that quarter or other policy things that come into place. I will say COVID was probably the biggest impact around the transaction activity. And frankly, when we started the conversation, we talked about hospitals and we talked about all the ancillary and outpatient and what we call the continuum of care around acute. All those organizations were frozen during COVID. We didn't know exactly how to deal with it. There was a lot more focus on patient care and a little bit less on strategic direction going forward for obvious reasons. We had to take care of something we hadn't seen probably in this generation in some time. In addition to taking care of those patients, though, it reset the strategy going forward. Some organizations saw a market shift in how they're going to serve their patients going forward. They had to redevelop and rethink their strategic plans in 22, 23, and even into 2024. So what we're seeing right now is a move back to that strategy, which is what should drive M&A activity in the first place. What's your strategy, and how can M&A help you execute that more effectively? I think the change we saw in late 2024 was there was a lot of pause around some discussions to see what the new administration was going to do. And that's not a political statement. It's just we expected a significant amount of change because of which direction there could be in terms of leadership in the White House. And waiting to see what those changes would look like and how they would take place was really important for most participants in the industry. So I think that's why we saw a short-term drop in early 2024 that has carried over because of the deal-making cycle that's required into early 2025. But just our own anecdotal view of the market activity right now, we're seeing a return to a lot of activity in the partnership arena right now. And that's going to manifest itself with a similar level of announcements that we would see in the back end of this year. And then I think it's going to accelerate to pre-COVID levels, even in 26 and 27 shortly thereafter.
You mentioned the change in the administration. I know the Biden administration had expressed some concern about private equity ownership of healthcare practices. Some of the concerns are around how it can maybe lead to higher costs and lower quality of care. Has the Trump administration, have they signaled more openness to PE ownership?
Yeah, Jed, higher costs and low quality care, those assertions I think were downstream consequences of perhaps a bigger thing that I think the Biden administration was most focused on. And I think that what they were most focused on was a high degree of market concentration on behalf of those private equity companies in market. For example, they could look at a regional market and say, look, by amalgamating all these specialty providers and dermatology, orthopedics, just pick one, right? Any area of medicine, that putting together that much concentration of those physicians, those caregivers, those clinicians in a market, they now have the ability to operate with a level of market concentration that does lead to higher costs for consumers or buyers of those services, and perhaps a limited or more limited focus on the quality of care that you might see from traditional health systems. So I think that part of market concentration was really the issue. In terms of the current administration, I do believe we're going to see a continuation of the high degree of rigor around market concentration. That has not changed. I think where we may see some differences, however, though, is that there seems to be a general openness to the laissez-faire view of market forces. And so we have not yet seen enough evidence of where that tug of war is going to land. But I would expect this current administration to be very focused on private equity ownership models that do result in high market concentration as being an area of focus from a regulatory standpoint.
So what does that mean for private equity? Do you see them being more active or less active in the space?
Two things. I think private equity has generally favored the physician side than it has the hospital side of the healthcare delivery business. And I think careful attention needs to be paid to market concentration going forward. It used to be at a time that when we looked at healthcare services companies, and this is the FTC's own precedent in terms of enforcement, it used to be on inpatient market share. And I think where the FTC has turned, and this is apolitical to the administration, we saw this even in Trump's first presidency, continued in Biden's, and perhaps is going to continue with Trump's second presidency too, is that the market concentration definition has always been a little bit more narrow. So the guidance and counsel to private equity firms or physician practices who are thinking about these transactions is I think we're going to have a lot more peripheral vision, a lot more deeper analysis of how does one define a market? How does one define concentration? And are we getting into a situation where, from a regulatory standpoint, we're going to be in the crosshairs of those reviewing these transactions? So I think careful attention does need to be paid by private equity firms who are thinking about growing in those markets. To the extent they're more widespread across markets, I don't think there's going to be a slowdown in their interest or in their activity. And I also think that the private equity firms are going to get a little bit more involved in alternative models that just don't focus on one specialty line. If we look at what happened with Summa and Hatco, which is a General Catalyst holding organization, you can see that they went directly into a hospital provider space. We haven't seen that happen in some time. So I think we are going to see continued private equity ownership with a mindful eye to market concentration and perhaps a more openness to other types of market entry strategies beyond just specialty care.
Okay. And talking about the administration here, how do you foresee the one big beautiful bill affecting the strategic decisions of hospitals and health systems moving forward?
I think the bill impacts every participant in the market. Now, at varying degrees and varying levels, is definitely going to be a market or payer mix specific element. And by payer mix, we mean how much revenue you get from government payers, Medicare, Medicaid, as part of your throughput of your patient activity. That's going to be impacted by certain organizations at a much higher level than others. What we do know is the tone and direction of the bill is a continued phenomenon we've seen in the industry for a number of years, and we're approaching a decade. And that is that we are looking for providers of care to do more with less. That reimbursement is unlikely to keep pace with the level of expense growth. And that's naturally going to create a situation where, all things equal, you're going to see an erosion of any margins that are there. For organizations that are borderline in terms of margin creation and margin performance, they're probably going to be in the negatives, and those are in the negatives stand to be much more in the negatives. I think the bill is going to make it more difficult in general for hospitals and health systems to move forward. I think we're going to have to see some reconciliation of some removal or changes in the bill that need to be bridged and that need to be providing for a softer landing for some of the health systems and other healthcare organizations that are impacted by the bill. That has yet to come out. One good thing about this industry, it's very resilient. It's creative in its approach, and it thinks about alternative mitigating strategies to large policy changes like this. And we've seen that in the past. Some of those mitigants are not yet clear and are still being developed. Some of those are going to be market specific and state specific. But generally speaking, I think the bill is going to create even more industry headwinds and more challenges for the vast majority of providers of care in our ecosystem.
Your report that your firm brought out recently also mentioned that there could be some sort of new partnerships being developed to deal with some of those headwinds. What types of new partnerships do you envision? Is it simply consolidation, or could it involve opportunities for new revenue streams such as joint ventures?
Joe, it's a great question. I think the best way to understand new is first talk about old. We were in an environment where I think there was safety and scale for a very long time. And by scale, it meant let's just put two organizations together. Let's find avenues to grow top line revenue. And we can always figure out the infrastructure and the fixed cost base below being mitigated, and you create economic margin. And not-for-profit health systems did this just as much as for-profit health systems. We saw the large emergence of the national organizations also looking getting into new markets. If they were religiously sponsored, they're called ministries, but they would get into these new markets, and you were looking for growth for scale. And so as long as you could create accretion by increasing revenue and managing the expense base, you create more economic margin that fuels either shareholder returns if you're for profit or more mission investment if you're not for profit. What changed, and what I think we're really going to start to see take hold a lot more clarity going forward, is that dynamic of expenses outpacing revenue that we just talked about in reimbursement, that is now a set case. That is not we're a couple years of this and we'll be fine. We are now on a number of years running where expenses outpacing revenue. That means scale probably isn't going to work. What we're going to need more of is specialty. And what that means is if you're an operator of a health system and you've done a very good job with your inpatient care chassis, you know how to take care of patients, you know how to move them in and out of inpatient rehab, you know how to move them out into a senior living if they're elderly and bring them back in for care, you know how to do tests and labs and everything else. It's possible that as an organization, you just didn't have the focus or attention you needed on something like urgent care or outpatient or maintenance of health, not just taking care of the acute episodic care that's needed. So that partnership model is, in this same example, an organization may look and say, we've got the inpatient covered. We need to partner with someone on the outpatient side. That could be a health plan. That could be a developer of outpatient sites. It could be directly to primary care physicians and say, look, we need to do something complementary here. And if we hardwire this network, we think we can get greater outcomes. We have the ability to share data and share patient records so we can become more efficient. But maybe we're resetting the game here. We're not just incrementally looking for cost savings of scale. We're actually taking the attributes of our two organizations. We're creating true strategic synergies that can be realized over the long term. That's an example of what we cited in our report. What we're starting to see here is a shift and that these hard and fast lines of you're a provider, you're a physician, you're a health plan, they're starting to come down a little. And not only are we seeing collaboration, we're seeing partnership and transaction opportunities across those once well-defined verticals that are creating collaborative models with organizations that heretofore might have been seen as disruptors or even competitors to what we're trying to do. And now they're actually our form of collaboration. I think that's going to be positive for the industry. I think it's going to open our eyes to an idea of we can strategically align with an organization that used to be an adversary, and together we can do something better in a way that is accretive to both the organizations from both a strategy and mission perspective, but also from an economic and operating model perspective.
So the consolidation, it's not buying similar institution, it's more buying different parts of the continuum.
That's exactly right. I think, are we going to see hospitals and health systems continue to transact? Yes, because we said strategy is critical and that might happen. But what is a lot harder to track, and what we would posit as a very important development to support our theory on this, is that for all the hospital and health system activity that has been going on during COVID, and we talked about how the numbers dropped a little, they were a little bit lower in 2024, the proliferation of hospitals with other types of health service system providers, that has continually grown throughout this process. So an urgent care center that is even private equity owned, partnering with a health system to say, look, let us manage these sites for you. We're very good at it. We're getting to this model of where hospitals and health systems, they need to organize the full care continuum, but they're often not required to own all of those components. They are doing a little bit more outsourcing, a little bit more joint venturing, a little bit more partnering with other types of organizations. And I think we're headed into that competitive dynamic that we see in most industry transformations, where the ultimate buyer of care is focused on better, cheaper, and or faster in terms of how they get healthcare services. And so for some health systems, that's going to mean relinquishing some control or influence on certain elements of their continuum of care to others in the marketplace based on their collective benefits divided by risks, them doing something better, cheaper, or faster than the health system can do.
So are some buyers better positioned than other buyers in that scenario?
I think so. But again, in each market, it's a little bit different because you have capital now and you have capital to spend, if you're still making the wrong strategic choices and thinking about your market in a way that isn't dynamic for where the needs of healthcare are going, you're at risk for putting a lot of capital use to non-creative opportunities. On the same side, there are small and medium-sized hospitals and health systems that are very tactically and specifically finding out and seeking out the specific partnerships that can advance their strategy. And even though they're not making the same level of investments, and even though those investments aren't as large, they may be significantly more successful because they're targeted and because they're executed really well. Ultimately, we're still back to strategy and execution, which I think is a good thing, because if organizations have a very clear point of view of what they're trying to accomplish, they very clearly vetted and tested how they can get there, and they're focused on the execution of doing so, that's what's going to breed success more than what level of capital or dry powder you may have to take on deal making.
Makes sense. Yeah, and you mentioned different markets. I wanted to ask you about the rural hospitals. Your report noted that Medicaid cuts will have a particularly significant impact on rural hospitals. So do you see this as an opportunity for more hospitals to open facilities under the Rural Emergency Hospital Program, which allows hospitals to offer emergency observation and other outpatient services and not inpatient services?
Yeah, probably earlier in our conversation, we talked about the bill and the mitigants and what can happen to create a commercial solution from what stems from ultimately a policy or a government-based catalyst. This is a good example that you just cited, Joe, of one. Rural hospitals right now are often the sole community providers in certain micro markets. So when you look at that community hospital, it could be, and take critical access as a good example of that. These are hospitals that by distance have to be far enough away from other hospitals, and they get special compensation within Medicare. Now, whether you're a critical access hospital or not, they both represent an opportunity in the community for those to get care that if it wasn't there, probably increases driving distance and honestly risk to patients by a pretty significant degree. What the government has basically said with this, the transformation for rural healthcare, is there is a belief that emergency care is really important in those hospitals. There's a belief that outpatient and ambulatory care could be very helpful in those markets. What's a little bit unclear on a market by market basis is, do you really need to have inpatient care in these hospitals and in these facilities? If you're running a census of 3 or 4 patients a day, that is a lot of infrastructure. That is a lot of cost in operations to invest to serve those patients. And if instead you could stabilize that patient and move them to another facility where they have access to more care, where there are much more resources, and you can do it safely and efficiently, that is a model that is being tested right now. Now, the answer is unclear, Joe. Not in every market is that going to be feasible or viable. And so there are going to be communities where we have to figure out a way to keep some of those rural hospital opens from an inpatient standpoint. But there are going to be other situations where some very difficult rhetorical questions need to be asked by these rural hospitals. And that simply is, what is our core business? We might have started out by having 30, 40, 50 patients inside of our facilities in the 50s or 60s or 70s when our hospitals were opened and really operating at their peak performance. But today, given technological change, given the level of movement into outpatient centers, given the ability of specialty clinics to take on some of that care, we may be operating as a society too many hospitals that are meant to address kind of the problems and the circumstances of something decades ago, half a century ago. For some of those hospitals, the movement to change into a new model, if taken on early enough, may actually do more benefit for their communities going forward, because they're pivoting to where care is going and they're not holding on to what is a smaller slice of their overall throughput of patient activity. I think that's an important change. To your point, Joe, it does represent an opportunity for a lot of organizations who are thinking about it for their own community and organization. But what we've also seen is, when that's done right, the increase in the level of interest from a larger health system to support that transformation is increasingly higher. In other words, whereas a health system might have looked at a rural hospital and said, look, your inpatient chassis is not sustainable. The level of flow you have isn't there. But if you're willing to change and conform to what your community wants, we want to work with you and bring you resources. We're going to bring IT systems. We're going to bring electronic medical health records and links to you. We might even have some opportunities to bring some of our specialty physicians out to your facility for a half day or day to do consults and say, yeah, this neurological procedure or this cardiology procedure, this needs to be done. You should schedule with us. We can make that booking with you right now and schedule that OR time here while we're on site at your hospital. So it is an opportunity for sure. Some will see it as a threat. And we're back to what fits in your market, what's your strategy, and what is really your core business. A firm understanding of that is critical in making the decision and the discernment between opportunity and threat.
So the point that you just made, I think maybe I'm wrong, but the report might have also talked about this as well, about how hospitals are pursuing deals that give them greater exposure to outpatient services. Is that kind of what you're talking about?
No. I think it is, but I also think that in this instance, with this example, with the transformation of rural healthcare, it is also coupled with a partnership strategy that didn't exist before. Because before, it would be the scale play, right? The rural hospital saying, we want to join a larger health system and we want to improve or increase our inpatient flow. You're at 3 to 4 patients a day. And by joining a health system, you're not going to be at 5 or 6 patients a day. Have you really incrementally moved into a sustainable model? Probably not. On the flip side, if you were to say to your community, we're going to take all our money and all our effort in developing this hospital as a recalibrated emergency room, and we're going to put urgent care centers in the market because we're pivoting to the model. If we can be closer to you in a rural setting, take care of your most immediate and most common needs, but also stabilize you to give you access to another health system for the very, very complex level of care that we couldn't provide anyway, maybe that's another business model. The nuance here is that there was a time where there would be a reluctance to that conversion and into that approach, because that community hospital would say, we're giving something up. Instead, now, yes, you may be giving something up, but you're actually getting something better in return, and you're getting a direct link to a health system. That is what's come out with some of the rural health transformation that we've seen, is that larger health systems who not so long ago might not have wanted to partner with these rural hospitals are very willing to partner with recalibrated rural presence that includes emergency services, outpatient and ambulatory, urgent care. That's a much more easy way for them to partner and to see a way to get a mutually beneficial relationship going forward. And again, those are anecdotal. They're starting to pop up in terms of transaction types. We're seeing more and more studies of those going forward. And I think it's a trend we're going to be watching going forward.
So those conversations that you're having with clients, are they getting more traction along
I
those
think
lines?
they are. I think we're seeing them twofold. One, we're seeing the number of those discussions increase, which is always a sign of volume. But two, we're also seeing a greater level of sophistication of where and how the integration process can be catalyzed, and the integration process can be optimized upfront. So if you know that the rural hospital is struggling with their electronic medical health record, and the larger health system has invested significantly in bringing those capabilities to other institutions, the ability to move it over to the other organization, there's a lot of muscle memory that's been there in prior acquisitions that's allowing it to happen a lot faster. And that's important for twofold. One, we're seeing physicians have a very strong preference for certain EMR, EHR systems, so patient record systems. But we're also seeing, particularly in rural environments, the movement to telehealth and doing some healthcare work, if you will, telephonically through mobile devices and through email, that's increasing at a significant pace. We thought that was coming generationally much later, but I think what COVID unearthed for us was there are members of our patient bases that were older and maybe a little bit more technology averse. They have flipped because they operated in a period of time they didn't want to go to the hospital for something mundane, something a little bit more ordinary, and ongoing ordinary course testing of a lab or a blood draw. It made them uncomfortable to go to the hospital during the pandemic. They're finding alternative ways to do that now. They're looking at germ consults being done with iPhones and things like that. So we're in a different phase right now. And I think to the extent that larger health systems have that offering immediately ready to go for some of these rural hospitals, it's going to add even more of a tailwind to move some of that integration discussion forward.
That's an interesting point. One last question I wanted to ask you before we wrap it up here is, I wanted to ask this because we've seen this in other parts of other industries as well. But your report mentioned that about half of the announced transactions in the second quarter involved divestitures. Can you expand on the motivations behind some of these divestitures for the larger health systems?
Sure. Yeah. Let's start with a little bit of context. I think the idea that the hospital health system arena is pretty fragmented, I believe is still true. There are a number of independent operators in the market. So when you look at commercial banks, when you look at airlines, when you look at almost any other industry, the level of kind of the top 10 organizations in those industries is very different when you translate that to hospitals and health systems. There are a significant amount of independent providers. What our report cited in divestitures was the large health systems that had created these large networks in multiple markets with multiple hospitals. They represented 62% of the transaction activity by selling some of their holdings in these markets. That's what a divestiture is in our industry, is that a large health system says, I no longer want to be in this market. I'm not comfortable with our strategic position, or I don't like the level of investment that's coming up to maintain that. I'm going to put this in the hands of someone else in that market. So that's what we mean by divestitures. And that high amount of activity is very significant in our industry, because what it means is that this idea that you could build scale that might have existed 10, 15 years ago as a strategic premise, that's no longer true. I think what we're finding is that the larger health systems are looking at the portfolio of offerings, meaning different markets and where those facilities are. And they're determining that, look, if we can't be in the top 3 in this market, we ought to put this asset in the hands of someone else. Let's transact and see what we can get for it. We are seeing both the for-profit and the very large non-for-profit national and regional health systems doing just this, that they are pruning their portfolio and thinking about where they can be more successful. So that is further proof that the scale model is now shifting more into a market focus model, a strategy model. And so if you have 2 or 3 community hospitals that never really came together or are still dealing with regional health systems around their market that are actually doing better in some of the transformation of healthcare, you're going to be more apt as a health system to say, then let's divest those assets. And that's what the report indicated for the 2024 activity and is continuing into 2025, is there's a lot more shuffling of the portfolios, both for-profit and non-for-profit health systems across the country.
So it just gets back to your earlier point that expenses are outpacing revenue.
I think that's part of it. I also think that even if you were a health system who had figured out the calculus around outpacing the revenue and expense, so maybe you're a large enough health system that scale got you so far that those assets are still performing somewhat well, you're probably looking at the future and saying, but wait a minute, our ambulatory platform is nowhere near the level of investment that the other health systems have done. Or the other health systems have invested in health plan capabilities. Maybe they have health plan partnerships, and it's getting increasingly harder to get the reimbursement we want. So you could still be performing well financially and operationally, but strategically, what's required to make those assets really hum in their markets may be beyond the level of investment that some of these health systems are willing to take on. And that's why they're also divesting. So you're right, Joe. It could be that the revenue expense equation is out of whack. It also could be that the revenue expense is manageable, but there's still not a long-term strategic future for these organizations within that health system they're housed. And there may be more strategic value for others looking at those assets. And you want to pick a time where you have some degree or modicum of success from which to have that conversation to transact. That's what we're also seeing.
Gotcha. Okay, so everyone's rethinking their strategy in the current landscape.
Yeah, if there's advice that could be given to everyone, it's exactly that. Very critically evaluate your strategy going forward. What really is your core business? What really is it that separates you from the participants in your market? How is that going to change? And I think the last litmus test that I think organizations at times can be reluctant to do but needs to be done is there has to be a very clear inventory of all the items that led to historical success of the organization, and then a critical critique of what of those are going to be really required going forward. In other words, how do we have to shift our strategy? What initiatives are going to have to be novel and new to take on the transformation that's ahead of us? And I think that's critical. Sometimes it's very easy to say we've been successful in the past, we'll keep doing it. That only works in a stable industry. And if there's something that can be said about healthcare services that I think everyone would agree, we are not in a stable industry. The transformation is real. And the multiple headwinds that we are facing from an economic standpoint, a policy standpoint, a regulatory standpoint, and a reimbursement standpoint, those are very clear. And adopting past success principles is probably not going to lead to future success. We need to have more time in front of the windshield and less time looking at the rearview mirror. And that's counsel and guidance to all organizations and participants in this industry, right?
Okay, great. Anu, I really appreciate your time here. It's been a very eye-opening and insightful discussion. So thank you.
Joe, thank you very much. And again, thanks to S&P for focusing on what is a very unique industry of healthcare services.
Thanks. And that'll do it for this episode of the Pipeline Podcast. Thanks for listening.